Hello everyone, and thank you for attending today's webinar on contrast-enhanced mammography, a potential game changer in the breast care pathway, with Dr. Maxine Jochelson from Memorial Sloan Kettering Cancer Center in New York City. My name is Bonnie Cowan, Clinical Marketing Leader, Breast Imaging with GE Healthcare, and before we begin, I would like to cover a few housekeeping items. At the bottom of your screen are multiple application widgets you can use. All widgets are sizable and movable, so feel free to move them around to get the most out of your desktop space. You can maximize your slide area or screen by clicking on the arrows in the top right corner. If you have any questions during the webcast, you can submit them through the Q&A widget. We will try and answer these questions at the end of the presentation, if time permits. If we do run out of time, we will answer them later via email. Please know we do capture all questions. A copy of today's slide deck and additional materials are available in the resource list. We encourage you to download any resources or bookmark any links that you may find useful. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in the background that could cause issues. Webinars are bandwidth intensive, so closing any unnecessary browser tabs will help conserve your bandwidth. The webcast is being streamed via your computer, so there is no dial-in number. For the best audio quality, please make sure your computer speakers or headsets are turned on and the volume is up so you can hear the presenter. Some networks cause slides to advance more slowly than others, so logging off your VPN is recommended. If your slides are behind, push F5 on your keyboard and it will refresh the page. You can find additional answers to some common technical issues located in the Help widget at the bottom of your screen. An on-demand version of the webcast will be available approximately 1 day after the webcast and can be accessed using the same audience link that was sent to you earlier. At this time, I would like to introduce Dr. Maxine Jochelson. Dr. Jochelson is the Director of Radiology, Breast and Imaging Centers and a Professor of Radiology at Memorial Sloan Kettering Cancer Center, as well as the Associate Clinical Professor at Cornell Medical Center in New York City. Dr. Jochelson?
Thank you so much, Bonnie, and we're going to get started. So, so you see, I have received financial support for this webinar. So the topics I am going to cover today are the theory of contrast mammography. I'm going to review available clinical data, show some cases, discuss potential uses, and where we're going in the future. I'd like to start with an example. This is one of those run-of-the-mill, heterogeneously dense breasted women with a mammogram that looks completely normal. However, she had an MRI, and you can see that there is an enhancing mass that is completely mammographically occult. And this is her contrast mammogram. This is one of the original units available many years ago. Mammography is the only imaging examination that has been demonstrated to reduce breast cancer mortality at this point. It is inexpensive, widely available, but the sensitivity is not perfect. 70 to 85% in the overall population, but this drops significantly in women with dense breasts and increased risk. Many years ago, Dan Copans demonstrated that if 100 women who had breast cancer were screened with mammography, 85% of those cancers would have been detected on mammography, 15% would have been detected by physical exam, and 20 of the patients would have an interval cancer presenting with symptoms because it was not detected on the original mammogram. The tumors that are more likely to be missed include infiltrating lobular carcinomas, uncalcified ductal carcinomas in situ, well-defined masses that are often associated with more aggressive tumors, and small tumors that are not spiculated. at least 2 to 9% of breast cancer is truly mammographically occult. Over the years, breast MRI has been increasingly used for the additional detection of breast cancers. It is the standard supplemental exam for women with high risk or greater than 20% lifetime risk for developing cancer. It is the most sensitive imaging test for breast cancer at this point, with a detection rate of approximately 97%. And this sensitivity is primarily due to its ability to image angiogenesis. The cancers detected are, in theory and in practice, more frequently invasive or higher grade ductal carcinomas in situ. In 2007, the American Cancer Society guidelines recommended that in women with a greater than 20% lifetime risk for developing cancer, an MRI should be performed in addition to mammography once a year. That accounted for several million patients. However, with patients with intermediate risk for developing breast cancer, which is a much larger group of patients, we still need to consider supplemental imaging over and above routine mammography. And the population here is much larger. There are currently over 3 million breast cancer survivors. There are over 15,000 women who have a diagnosis of a high-risk lesion, such as atypical ductal hyperplasia or lobular neoplasia. And even more significantly, women with dense breasts. As you all know, in 2009, Nancy Capello started a movement that women who had dense breasts were informed of their breast density and had a suggestion that they might need additional imaging. And this is a two-pronged problem. First of all, women with extremely dense breasts have a 4 to 6-fold increased risk of developing breast cancer compared to women with fatty breasts. Most important, however, is that the density of the breast tissue masks cancers, and that's why the sensitivity goes way down. These women have a higher interval cancer rate, often presenting with larger tumors. And I like to kind of show a dense breast in relationship to a freeway in Los Angeles, where if you're trying to pick out that one red car, it's really hard to find. We have anatomic options for supplemental imaging. Tomosynthesis, which now is almost always used for screening in about 30% of the centers in the United States, can also be used as a supplemental exam, and it detects an additional 1.5 to 2 per 1,000 additional cancers compared to regular mammography. Screening ultrasound detects approximately 3.5 per 1,000 additional cancers. So if you add the two, you will get some additional cancer pickup in women with dense breasts. The largest trial evaluating screening ultrasound was the Akron 6666 trial, in which nearly 3,000 women with dense breasts and one other risk factor underwent screening ultrasound by expert physicians. They demonstrated an additional 3.7 cancers per 1,000 pickup rate. But the problem with screening ultrasound was not so much in the sensitivity, but in the fact that a large number of these women had recommendations for biopsies, 8%, and 93% of these biopsies were benign. The group from Italy compared tomosynthesis and ultrasound with women who had dense breasts and negative regular mammograms in the Astound trial. And the interim results that were published in 2016 demonstrated that additional 24 cancers were detected, 96% of which were detected by ultrasound, only half by tomosynthesis. What was more disturbing was at the end of the Akron trial, when women had had 3 rounds of screening over 2 years, and the screening was negative, 612 women were offered MRI. And in that population of patients, there were 16 additional cancers. 15 per 1,000 were detected with MRI, and over half of them were only seen on MRI, even when they knew where to look on the mammo and the ultrasound. So what this tells us is that a normal mammo plus a normal ultrasound may give patients a false sense of security that they're okay. Similar numbers were generated in the EVA trial, which Dr. Poole et al. Published in 2010, almost identical. Here you can see, using mammo plus ultrasound, a detection rate of 8 per 1,000, but with MRI, 15 per 1,000, and adding in that mammogram or ultrasound in addition to the MRI didn't give much additional benefit. However, MRI has its limitations. In the United States, it's extremely expensive. Patients are claustrophobic and don't enjoy the experience. Women with metallic implants, gadolinium allergy, are unable to have MRI. The scanners are not universally available for large populations of screening mammograms because many centers only have 1 to 2 MRI scanners which need to be used for neuroimaging and MSK imaging. And more recently, there is some concern that there are gadolinium deposits in the brain in women who have multiple MRIs. Whether this is clinically significant is unknown, but this certainly makes patients anxious. One way to make MRI more available is to use an abbreviated group of sequences, and Christiana Poole and colleagues prospectively read 606 women who had protocols that were done in 3 minutes compared to 17 minutes. The full abbreviated protocol took 28 seconds to read and had a sensitivity of 100% with a very high specificity. And even just reading this MIP image took 2.8 seconds to read, and in their hands, a sensitivity of 91%, far superior to mammography in women with dense breasts. However, this still will not make screening available to all women. So the idea of contrast mammography came up, and the goals of these additional imaging tests were for women with intermediate risk or women with dense breasts to improve sensitivity with a high positive and negative predictive value, limit the additional radiation exposure, low cost, and something that can be available to a larger population of women. And that really was what was thought about when contrast mammo was developed. Basically, contrast mammo is able to map blood flow just as MRI is able to do. Originally, this technique was done using what's called the temporal technique. And this is kind of like the old-fashioned angiograms. The patient would have her breast in compression. A baseline image would be performed prior to contrast injection. She then had her contrast injection, and several images were obtained over 5 to 7 minutes, and then a logarithmic subtraction was performed. Enhancement curves were generated just as are done with MRI. The initial results were promising. Enhancing cancers were detected. And in fact, in an early study, Beekman et al. Demonstrated significantly improved sensitivity in women with dense breasts using this technique. However, this was a flawed technique. Despite mild compression, women moved when they were standing for 5 to 7 minutes, not surprisingly. The curves generated on this technique were different from those with MRI, and that changed the specificity of the examination. And even more concerning is that you could only do one view of one breast per injection, and so that made it difficult to localize the images. Therefore, dual energy contrast enhanced mammography was developed. The unit looks like any other mammographic unit, and it is basically a mammographic unit that is adapted to perform both low and high energy exposures to produce what we have named the iodine image. This is a little bit of the technology fundamentals, which I will not dwell on, but basically the ability to do both images nearly simultaneously makes this possible. The low energy image is performed below the K edge of iodine and the high energy image above. And then with post-processing, one generates the iodine image. The contrast used is the same contrast we use for CT scanning. We do this via a power injector, ideally at 3 milliliters per second through a relatively large gauge needle. Generally, we give the patient the contrast while she's sitting. After she is done with the injection, she is disconnected from the injector and positioned for what she perceives as a routine mammogram. This starts about 2.5 to 3 minutes after the injection is complete, which allows the uptake of the contrast in the breast. There's even time to do more than just 4 views, and the whole examination is completed between 5 and 10 minutes. This is an example of an early contrast mammo that was given to me by John Lewin, who actually helped develop this methodology. And this was not done on a dedicated machine. This is the high energy image, which is kind of very blurry to look at. The low energy image is the equivalent of a digital radiograph, and so you don't need to do an additional mammogram. And this is the iodine image, and you can see this cancer that was hidden in the dense breast tissue very easily. So for the patients that have been having MRI, there is no new intervention. They're used to getting intravenous contrast, and this doesn't seem to bother them. And as far as they're concerned, they're having a regular mammogram, so this is very well accepted. The risks of this examination include those of giving iodinated contrast, and the incidence of contrast allergy in the literature is between 0.6 and 1.3%. We have to remember that although less frequent, women can develop an allergy to gadolinium, so one needs to be able to handle a contrast reaction. Renal failure is extremely rare if you screen your patients carefully, and we do not do contrast mammography on any patient who has potential renal impairment. The radiation dose that is given is the approximate equivalent of 1 additional mammographic view. What has been very promising is that across the world, the results are very similar. Clarice Romain and colleagues evaluated 120 women who had abnormal screening mammography or clinical symptoms. They performed unilateral contrast mammo and mammo with ultrasound in these patients and demonstrated a significant improvement in sensitivity using contrast mammo over and above mammography alone, and a trend towards improved sensitivity when compared to mammo plus ultrasound. Accuracy was significantly better using contrast mammo compared to mammo plus ultrasound because the specificity of contrast was so good. Mark Loebs from the Netherlands also demonstrated excellent sensitivity and specificity using contrast compared to mammography alone. The sensitivity is very good, keep in mind, because these are already women with abnormal mammograms. The group from Poland also demonstrated superb sensitivity using contrast mammo. Their specificity wasn't great with contrast, but it wasn't great without contrast, so this definitely improved as well. We did the first bilateral contrast mammograms in 2010 and demonstrated, to begin with, that we could easily do bilateral mammography, contrast mammography, after only 1 injection. We also demonstrated in a population of women with known breast cancers that contrast mammo was similar in sensitivity to MRI and both significantly better than mammography alone. Ava Fallenberg and the group from Germany did the same study in 80 patients. They also broke down the false negative mammogram and showed that the reason that contrast mammography improved the detection of cancer primarily in women with dense breasts. Fallenberg et al. Did a large reader study with multiple readers from across Europe, 178 women with cancers, and they demonstrated that the area under the curve for contrast mammography was significantly better than mammography alone and not significantly different from MRI. Many of us also demonstrated that contrast mammo was extremely accurate in depicting the size of the index breast cancers, and more so than any other imaging modality. Here is an example of one of our patients, a young woman who presented with some nipple retraction and had an otherwise unremarkable mammogram, except for a few calcifications that I can't even project. They were biopsied and demonstrated to be cancer. But look at the contrast mammo. You can see enhancement throughout the lower half of the breast. She had multicentric cancer that you can see on the MRI. But even knowing where to look on this low energy image, which is the regular mammogram, you can't find this cancer. Here is another patient from our original series, a woman who presented with a palpable mass. You can see on her MRI a solid mass, which was invasive cancer, non-mass enhancement extending to the nipple, which was ductal carcinoma in situ. And as you can see, the contrast mammogram shows the exact same distribution. This is just to reiterate the fact that the improvement in detection of cancers in dense breasts is better done with contrast mammo. The group from Taiwan also did a study dedicated to women with dense breasts, and they also showed significant improvement in sensitivity. And look at these numbers. I just want to point out that every single study I have showed you shows a sensitivity for contrast mammo of over 90%. This is another example of ours with a woman with a heterogeneously dense breast and this cancer hiding in the tissue here, which is beautifully seen on both contrast mammo and MRI. Now, what about patients who have microcalcifications? We are frequently scratching our head as to whether or not the women need a stereotactic biopsy. Dr. Chung et al. In Taiwan evaluated their population with suspicious calcifications, and they demonstrated only a 94% negative predictive value, so that they concluded, and these numbers are identical to MRI, that MRI or contrast mammo are not good enough to tell you whether or not you need to biopsy the calcification, because you will have false negative imaging in 6% of the population. And here are a few examples. This is a patient of ours who did have suspicious grouped calcifications in the upper outer breast, and these enhanced. This was ductal carcinoma in situ. This is another one of our patients, and I hope you can see that there are calcifications in the whole upper portion of the breast here. And you can see areas of non-mass enhancement with the same distribution as the calcifications, and this was ductal carcinoma in situ with microinvasion. On the other hand, here is a patient with similar appearing calcifications as the first patient, not a drop of enhancement. And whereas we were hoping maybe these were low-grade ductal carcinomas in situ, that was not true. This was intermediate grade with marked necrosis. So don't use contrast mammography to decide if you're going to biopsy calcification. The other common clinical complaints we see with our patient population are women who have palpable abnormalities. Tennant et al. Did a multi-reader review in a retrospective fashion of 100 women who had palpable breast abnormalities, and they compared contrast mammo to mammography alone. And as you can see, The sensitivity of contrast mammography is significantly better than mammography alone. We did a prospective study in women with palpable abnormalities. We had a population of 250 women, either self-palpated or physician-palpated. Now, we compared contrast mammo to our standard workup, which is a low-energy mammo plus an ultrasound. Our sensitivity was not as good as that of ultrasound. We did have 1 or 2 patients that retrospectively we could see the cancer but was missed, so the sensitivity was a little bit better than this. The specificity, on the other hand, of contrast was much better than that of ultrasound. And the positive predictive value of contrast mammography was significantly better than that of low energy plus ultrasound alone. So that what we concluded is that although doing mammography and ultrasound is quite sensitive without adding the contrast, using the contrast may enable us to avoid biopsying women who have benign appearing lesions on ultrasound that do not enhance. Here is a couple examples from the study. This is a patient with a triple-negative breast cancer who had refused chemotherapy and now presents with palpable abnormalities in her breast. Her skin thickening had increased slightly from her post-radiation images, but you don't see any discrete masses on the routine low-energy image. But look at this. There are innumerable enhancing masses throughout this breast, which were seen on ultrasound and were found to be recurrent triple-negative cancer. Unfortunately, she had diffuse metastatic disease as well. This is a patient of ours who had had a phylloides tumor, presented with a recurrent mass, and my surgeon was about to order an MRI. You can see the low-energy image. There's some increased density here, but you can't see this discrete mass. Well, she went on our protocol, and you can beautifully see this recurrent tumor. The surgeon was so pleased she did not do an MRI. Another potential use for contrast is in problem solving. This is a woman who came to see one of our surgeons with a 5-centimeter palpable mass. This is her mammo from 2014, 2015, and 2016. And the mammogram looks unchanged over 3 years without a discrete mass. The patient had had an outside ultrasound where they thought they saw something in this area where the palpable mass was most prominent. The ultrasound biopsy was negative. So I offered to do a contrast mammo on this patient. We gave her contrast, and as you can see here, she has diffuse enhancement throughout the right breast, and this was multicentric invasive lobular carcinoma, and therefore the patient went on to have a mastectomy. So a great example of using contrast for problem solving. Another potential use is to evaluate a patient after she's received neoadjuvant chemotherapy. There is a prospective trial that was recently published by the group from Italy involving 46 women. The studies were interpreted blinded to each other, and they demonstrated that contrast mammography predicted pathologic complete response slightly better than MRI, which was a really nice surprise. And here is an example of one of their patients. You can see a large enhancing mass on the contrast mammo, also seen on ultrasound and MRI. You can see there's a feeding vessel into this mass. During neoadjuvant chemotherapy, the enhancement went completely away, and this was a pathologic complete response. This is a study from the group from Mayo Clinic in Arizona, and they also demonstrated that contrast mammography was equivalent to MRI in both sensitivity and specificity for assessing response to chemotherapy. Here is an example from their population of patients, heterogeneously dense breast without being able to see the cancer, but you can see it beautifully on contrast and MRI. And then after treatment, complete response. We are also doing a similar study, and hopefully one day women will be able to have contrast mammo rather than the more expensive MRI. Another use for contrast mammo is in women who have had lumpectomy to better evaluate their breasts, especially those women with dense breast tissue. This is a patient of ours who was 54, who had had multiple prior biopsies and then had triple-negative breast cancer in her left breast. Basically, these very few calcifications shown here were her presentation for triple-negative cancer, a very unusual presentation. 2 years later, she presented for a routine screening of her contralateral breast, heterogeneous breast tissue, nothing obvious on the low-energy image, but look at this non-mass enhancement in the upper outer quadrant. Surprisingly, this was also triple-negative breast cancer. Here it is on ultrasound. This is a woman who 1 year earlier had presented with a low-grade and estrogen receptor-positive small breast cancer. She had a lumpectomy with clear margins. She underwent radiation therapy and was taking tamoxifen and came in for her routine 1 year follow-up. You never expect to see recurrent disease this early, but lo and behold, she had multiple enhancing masses both in the lumpectomy site and extending down throughout the breast. This was the ultrasound of one of these masses, and she did in fact have recurrent or persistent tumor. So we looked at the fact that contrast mammography was so good in the diagnostic setting, we thought about using it for screening intermediate women. We completed a prospective trial comparing contrast mammo to breast MRI to determine how the performance of screening contrast compared to MRI in women at increased risk for developing breast cancer. It was a prospective IRB-approved trial, and we allowed women greater than 21 years within the trial, and they have to have their contrast mammo and MRI within 30 days of each other. So this was a very heavily pre-screened population. They had all had multiple screening MRIs, and therefore, the good news for them, there were very few cancers. The bad news for us, there were only 3 cancers upon which to base our data. However, we were able to show that no cancers detected on mammography, 2 invasive lobular cancers seen on contrast mammo and MRI, and there was 1 very tiny BCIS. It was actually a small focus on the MRI. The patient returned 9 months later, and it was a typical ductal hyperplasia, which was upgraded as surgery. At 1 year follow-up, there were no interval cancers and only 2 screening detected cancers. We also looked at specificity. Now, keep in mind that these patients had multiple prior MRIs, which improves the specificity, whereas only 1 of our patients had a prior contrast mammo. Nevertheless, the specificity was equivalent, and definitely once you have prior contrast mammos, your specificity will improve. Here is an example of one of the patients. She had a heterogeneously dense breast and a history of lobular carcinoma in situ. Here is the cancer hiding in the upper part of that breast, which is seen on contrast mammo and MRI. Of interest, on the axial images of the MRI, there were 2 areas of enhancement, and I was very disappointed thinking that contrast mammo had missed 1. But when she presented for her biopsy, only this one remained, so that they were equivalently sensitive and specific. My colleague Janice Sung has recently presented early data in a study comparing contrast mammo to screening whole breast ultrasound. For the first 250 patients, we found 5 cancers, 1 on mammography, 2 on ultrasound, and 5 were seen on contrast mammo, suggesting that contrast mammo may be better than ultrasound in this early data. Here is an interesting example. This patient had heterogeneously dense breast with a history of lobular carcinoma in situ. The low-energy mammo is completely normal, but there is a round enhancing mass in the posterior breast seen on both views. She underwent an ultrasound, and the ultrasound was negative. We therefore did an MRI, and the MRI showed an enhancing mass, which I'm sorry is not projecting here, and that was biopsied to prove to be invasive ductal carcinoma. We recently presented our accumulation of over 1,000 patients that we have done for screening, and we have demonstrated that contrast mammo depicted 18 per 1,000, which is similar to MRI. So here is another patient from this population of screeners, heterogeneously dense breast tissue, and a very small enhancing mass is seen in the lower inner quadrant of the breast. This is a slide given to me by a colleague from Japan, Dr. Mitsutani, who saw a little bit of distortion on a low-energy mammogram. And here you can easily see the enhancing cancer. This is a patient from our routine screening population who had a heterogeneously dense breast, some vague focal enhancement in the mid to inner portion of the breast. Our standard protocol is to do ultrasounds on these, but for some reason that didn't get done, but she was sent for MRI to see if we could find an area to biopsy. The MRI was completely normal, so she came back 6 months later and had this finding on ultrasound. We repeated the contrast mammo, and lo and behold, it was the lesion that we saw in the contrast mammo, which was a true positive contrast mammo and a false negative MRI. This is a patient we recently saw who had heterogeneously dense breast and negative low energy image. And one of my brilliant colleagues found this tiny enhancing mass in the lower inner portion of the breast. My equally wonderful ultrasound technologist was able to find this small invasive cancer. The degree of enhancement has often been suggested to be a way to differentiate malignant from benign lesions on contrast mammography. But this is slightly controversial. Most studies do demonstrate that the correlation between morphology and enhancement are critical, but that the morphology and the characteristics of the morphologic lesion are the most important thing to look at. However, I'd like to show you a case. This is another lobular carcinoma in situ in our population, and you can see very, very faint enhancement, mirror image in both breasts. This lady went on to have ultrasound, and the ultrasound showed invasive lobular cancer. We have recently completed a study and are in the, it was just presented at the European Congress of Radiology, where we looked at enhancement of invasive lobulars and compared them to invasive ductal cancers. And in fact, patients with invasive lobular cancers have less enhancement than those with invasive ductal cancer. So it is really important that even if you have a faintly enhancing lesion, that you go forward and work it up for cancer. This is a study that was loaned to me by Dr. Sean Leon from Texas. This patient had multiple different degrees of enhancing lesions, and he biopsied several of them, and all of them had the exact same diagnosis, invasive ductal cancer. So we really are not sure yet why there's such a difference in enhancement on these patients. Many people have looked at patient preference when you do contrast mammo compared to MRI. In 2 studies, there was significantly higher overall preference for contrast mammography. The patients felt that it was faster, less noise, and greater comfort. The first study was from Australia. This was from Boston. So again, and I've spoken to many patients, they would much rather have a contrast mammo than MRI. Now, one of the problems so far is that there is not yet a biopsy mechanism to do a biopsy if you only see the lesion on contrast mammography. So far, if we see it on low energy images, we can do a stereo. If we see it on ultrasound, we can do an ultrasound core. And most of our patients that we have not been able to see it on either mammo or ultrasound, the lesion is seen on MR and we can do an MR biopsy. But that kind of defeats the purpose. So hopefully the biopsy mechanism will be out and available soon. Here is one interesting way of getting tissue if you can't do that at this point in time. So this is also from Dr. Leong. He had this patient who has this enhancing mass at 6 o'clock. What he did was he used the anatomy, surrounding anatomy, put a wire in the patient's breast, then injected the contrast. And this documents that the wire is in the right spot, and the surgeon was able to remove this cancer, and you can see it here on the specimen radiograph. What about background parenchymal enhancement? We know that on MRI, it has been demonstrated to be related to risk for developing breast cancer. We did a study to see how contrast mammo BPE compared to MRI. And we used the same 4 categories, and we demonstrated that there was, in fact, substantial agreement between the two when looking at BPE. And when we did a subgroup analysis of the associated clinical factors, they were similar. And this is just an interesting example of what we call moderate BPE on contrast mammo. In the same patient, you can see very similar appearance on MRI. And this woman has marked background parenchymal enhancement seen similarly on both exams with a simple cyst in the middle. Now, there are false positives with contrast mammo, and although they are fewer, we still really need to know what they look like and what they may mean. This lady had a palpable abnormality. She has moderate background parenchymal enhancement, thinly enhancing rim simple cysts, and then she had this thicker enhancing cyst in the center of the breast, and we know from MRI this is just an inflamed cyst. This lady had an irregularly rim-enhancing lesion that we point to here, which was very suspicious. However, she was part of our study, and what is really nice about MRI is you can do a non-fat subtracted image, a non-fat suppressed image, and turns out she had a biopsy here, and this is just fat necrosis. This lady had this very asymmetric diffuse enhancement, and this was pleomorphic lobular carcinoma in situ. There was no cancer at surgery. This is her MRI, which showed very similar appearance. So how is contrast mammography going? Well, currently in the United States, there are over 180 installations of contrast mammography units from various vendors. Many places have more than one. And these are our numbers. So we began doing contrast mammo for a research tool in 2010. In 2011, we went to the FDA and it became approved. And here are our numbers from 2013 when we really started using it clinically to now. And we are, in fact, doing well over 1,000 patients a year. And the reason for that is that our clinicians are really happy with this technology. So what are the potential indications? Well, certainly most of the early studies have been to use it as a diagnostic tool, and I think it is superb as such. Problem solving, staging known cancers, follow-up after neoadjuvant chemotherapy, follow-up after lumpectomy, a method to improve biopsy selection, and I truly believe screening for intermediate and some high-risk women and women with dense breast tissue. One of the things we've suggested to our genetic doctors is that when you're doing women with mutations, since they're getting yearly MRI, to use contrast mammo as the alternating exam when you're doing every 6-month studies, and we've actually begun to do that. Future directions include multi-center trials comparing contrast to MRI, and even more importantly, contrast mammography to tomo plus ultrasound. We also are going to further investigate the possibility of using the lack of enhancement in an otherwise benign appearing lesion to avoid biopsy. And we are trying to develop, and I shouldn't use the term BI-RADS, but we're trying to develop a lexicon so that everybody uses the same language, just as we do with BI-RADS. And what we've currently started working on is something that's going to combine the BI-RADS Mammo 5th edition for the low energy images with the MRI BI-RADS, except for kinetics, and using a combination of the two, come up with a recommendation for what to do with the patient, so we're all on the same page. So the contrast mammo theory has been put into practice. We have been able to demonstrate improved cancer detection compared with mammography alone and probably mammo plus ultrasound. We find that contrast mammo does approach the accuracy of MRI for cancer detection. The tumor size depiction and pathology is extremely accurate. Most patients prefer contrast mammo to MRI. The potential for screening is very exciting. It's low cost and can be easily available to large populations of patients. Referring doctors, and particularly in our population, our surgeons really love this technology. It's very easy to sell. We have accomplished a great deal, and we have a great deal left to do. So I thank you very much.
Thank you, Dr. Jochelson, for a very informative presentation. We did have some questions coming in from the audience, and so we're probably going to look at maybe taking 2 or 3 questions based on the time. So the first question is, how long did it take you to get comfortable with interpreting the CESM exams and, confident in the results that you were seeing?
No, it's actually fairly simple. Just like any other technology, there is always a case that's a little bit difficult, but this is actually, especially because I've been reading MRI for years, it's very quick. And now that, and we first started doing this with only 4 of the people in our group reading them, and slowly but surely we are introducing it to all the other people in the group and have been, and it actually is a pretty quick uptake.
Great, thank you. One of the other questions that came in was, what changes did you need to make, to be able to implement the CESM technology into your department?
We are fortunate in that on the floor above us, we do MRI, PET, and CT, so we have a large number of nurses who start IVs. So when we first started, we were able to get them to come downstairs and help us. We are now doing so many contrast mammo studies that we have actually added a department nurse who can actually help us both with doing the IVs as well as helping us with our large biopsy population. So you do need to get some ancillary help to get the IV started. Once the patient has the contrast, the study itself is quick.
Perfect. Okay, and then we'll just take one last question is, how do you handle women, imaging women during their cycle?
So we do not time our contrast mammo exams according to cycle, and in fact, we do not do that for MRI as well. And if you look at the literature, we've recently published a study demonstrating that it really doesn't matter when we do patients in their cycles for MRI, because the sensitivity for cancer detection is no different regardless of when the patient is, where the patient is in her cycle. There have been other papers on that in the past. Dr. DiMartini and colleagues had also demonstrated this. So we do patients as they come. It is way too complicated to try to do things based on cycle, and we have no scientific evidence to demonstrate that it makes a difference.
Okay. Thank you very much. Well, we're going to go ahead and wrap up now. I want to take this time to thank you for taking the time to attend the webinar today. And please look forward in the future to GE Healthcare's clinical conversation webinar platform. Again, a day after the webinar, we will be posting the on-demand link for you to revisit the webinar at your convenience. So again, thank you, Dr. Jochelson, and we'll be in touch. Thank you.
You're welcome.